طيب بسم الله الرحمن الرحيم نبتدي الآن. This presentation is just to highlight few points about the biologic treatment in CRS with nasal polyps. This is first slide demonstrates the role of IL-4 and IL-13 in type 2 inflammation. Also, this slide shows the role of IL-5, which is not covered or not, the receptors of IL-4 is not, the Dupi doesn't work on that. As you know, the treatment of CRS with nasal polyps takes a stepwise approach depending on the severity of the disease. In mild cases, we start in saline irrigation and intranasal corticosteroids. In moderate cases, we use short-term antibiotics, courses to treat infections, and short-term systemic corticosteroids. In severe cases, most of the time we use surgery to remove the nasal polyps, followed by medical treatment. Even though with this procedure, we still have recurrence of the nasal polyps, and we do revision surgeries, and we continue to give medical treatment with no result. Just to know where we stand now in the treatment of CRS. We use systemic corticosteroids to control the nasal polyps, but this is not recommended for long chronic cases because of the short and long term adverse effects of the corticosteroids. Of course, CRS is an inflammatory disease of the mucosa, and surgical removal of the polyps doesn't treat the underlying inflammation. Also, it doesn't really help in improving the sense of smell. And we will need repeated surgery, and it is not a pleasant experience for the patients. We have biologic therapies, but this doesn't target the key main mediators. So what we need is, in the future, a biologic therapy which targets the exact mediators involved in the inflammatory process. As you know, the goal of treatment of severe CRS is to reduce the polyp size, to decrease the use of systemic steroids, also improve the airway and control infectious complications. When do we use the biologic treatment? There are 4 criteria, 5 criteria for the use of the biologic in the treatment of CRS. The first one is the evidence of type 2 inflammation, the need for systemic corticosteroids in the past 2 years, also the significant quality of life impairment and significant loss of smell, and diagnosis of morbid asthma. Actually, it is evaluated or weighed on equally, but I think some of them should actually weigh more than the other criteria, like evidence of type 2 inflammation. You cannot compare it with hyposmia. But anyway, that's a different story. And these criteria, it depends if the patient with the nasal polyps have a history of surgery, then the 3 of these criteria may be enough to use the biologic as a treatment. If there is no history of surgery, then 4 criteria are required. We use these same criteria to evaluate the results of the treatment of CRS. As we said, they reduce the nasal polyp size, reduce the need of steroid corticosteroids, improve the quality of life, improve the sense of smell, and reduce the impact of comorbidities, asthma mainly. Dupilumab was approved in June 2019 as a add-on maintenance treatment in patients with severe severe or inadequately controlled CRS with nasal polyps. This slide is to highlight the role of IL-4 and IL-13 in inhibiting the signaling pathways of inflammation type 2. It works on the receptors of IL-4 and IL-13. We discussed that before. Right, Dupilumab, this study showed Dupi had significantly reduced the nasal polyp size. It also improved the radiologic signs of sinus disease on CT scan, and using the Lund-Mackay CT score. It also improved the nasal congestion, also improved the smell sensation. And these graphs show when we stop the medicine, when we stop the biologic with Dupi, the condition will deteriorate. And so that indicates the continuation of Dupilumab for a longer period is indicated. Also, there is improvement in quality of life. Also reduces the systemic use of systemic steroids and the need for revision surgery, and improves the comorbid disease like asthma, improves the lower airway conditions. This is just to repeat the thing that it reduces the size of the nasal polyp, sustained improvement of the smell, and reduce the corticosteroids, and improve the quality of life. And Dupilumab was generally well tolerated in patients age 18 and above. And now, I'll come to some figures here to show the results of the study. Dupilumab, 57% of patients had improvement in nasal congestion and obstruction severity. 33% reduction in nasal polyp size. 42% improvement in sinus opacification. 52% improvement in loss of smell. So you see the results. These percentages, of course, maybe when you look at it, it is not convincing, but in fact, in reality, it improves the conditions of the patients and the quality of life. The 74% of patients showed reduction of systemic corticosteroids. 83% showed a reduction in need for revision surgery. This is compared to a placebo group. So as we said, it reduces about 75% the need for steroids, and revision surgery was reduced compared to placebo group. I just want to highlight something about endoscopic endotyping of CRS. As you know, we have endotypes and we have phenotypes. Phenotypes is chronic rhinosinusitis with polyp and chronic rhinosinusitis without nasal polyp. As from the discussions before, there is no clear cut between chronic rhinosinusitis with nasal polyp and without polyp. In the United States and Europe, the vast majority of CRS with polyps associated with type 2 inflammatory response, characterized by eosinophils, mast cells, basophils, elevated IgE, and certain cytokines. But in many Asian countries, only 30% to 40% of cases of CRS exhibit eosinophilia. And that will reflect when we discuss later about how do we investigate for the type of the inflammation that we have. Because some may necessitate to have eosinophils. eosinophilia and high IgE before prescribing or starting the biologic treatment. CRS has been, just a quick review, CRS with nasal polyps associated. So إبراهيم هاي سكرين تقدر توصلها
دكتور لازم تفتح على السكرين. احنا هاي شايفين هاي السكرين البيضاء؟
ايوه
شايفينها.
CRS with nasal polyps associated with T1 helper cell cytokines, upregulated tumor growth factor beta, upregulated interferon gamma, and low ACP. More recent research showed that the inflammatory response in CRS without nasal polyps is actually heterogeneous. Type 1, type 2, or 3 inflammatory, with up to 50% of cases being type 2. Complicating things further, there can be mixed expression of T1 helper and T2 helper cytokines in the same patient of CRS. So you see, it's the inflammatory process in chronic rhinosinusitis is very complicated. It's not as easy as we think. So when we have a medicine biologic work on 50% of patients or reduces the need for revision surgery of 83%, this is a great achievement for the time being, actually. Now, how would you treat patients? We need two things. How would you treat patients with biologics? We need a biomarker to tell us what type of inflammatory process is going on. And depending on these biomarkers, we can give the exact or tailor the treatment for each patient and give them the exact biologic therapy. So as we said, it's better biomarkers to better target therapy for CRS, and researchers are investigating the use of biomarkers for endotyping. The biomarkers are different, divided into eosinophils, like tissue and blood eosinophilia, type 2 cytokines, as we discussed, the IL-4, IL-13, and IL-5, immunoglobulins, IgE, IgG, IgA, and markers of tissue remodeling. From this, you know, this is the steps in the inflammatory process, and for each step there is a biomarker. Okay, and right. These are some abbreviations I'm going to use in the other slides. Right, let's just go through the biomarkers quickly. Tissue and blood eosinophilia. General eosinophilic chronic rhinosinusitis with nasal polyp responds to steroid therapy, whereas non-eosinophilic or neutrophilic chronic rhinosinusitis with nasal polyp does not. Tissue eosinophilia predicts greater CRS severity and prognosis after endoscopic sinus surgery. That's what we need after surgery, an exact, a detailed histopathological report telling us the severity or the degree of tissue eosinophilia, so we can plan our treatment accordingly. Blood eosinophilia does not necessarily reflect sinus tissue eosinophilia, and use is limited in this matter. Type 2 cytokines, IL-5 positive nasal polyps are associated with higher risk of concurrent asthma and CRS and greater need for revision endoscopic sinus surgery. IL-4, IL-13 activate type 2 inflammatory process, as we said. So these are tell us, the biomarkers, as I said, tell us about the process or the type of inflammation going on. Now, accumulating evidence for newly identified epithelium-derived cytokines affect type 2 inflammatory response. immunoglobulins, mucosal tissue, IgE is a major contributing factor in CRS with nasal polyps. But high levels of IgE predict risk of CRS with nasal polyps recurrence requiring revision endoscopic sinus survey. So I think we should do request an IG level in every patient with chronic rhinosinusitis with nasal polyps. IgG and IgA autoantibodies are highly elevated in nasal polyps and may indicate more severe clinical course. MMP9, which can degrade the ECM, which is the extracellular matrix, is increased in nasal polyps. This is the destruction phase of the inflammation, where we get tissue destruction and the release of these biomarkers. Well, there is no significant correlation between MMP9 expression and severity of CRS with nasal polyps. It actually indicates poor healing rather than the inflammatory process. Biologic. Well, in the future, which is now, endotyping may be used to determine the inflammatory process within a mucosal tissue and allow for tailored therapy for patients with CRS. I think we are in the beginning of this process. Dupi maybe is the first one in CRS, but I think next year another one will be approved. As we said, we are targeting the inflammatory process. Anyway, cytokines. The targets for the treatment, like the Biologic, works on target key mediators. These mediators include the IgE. IgE role in the inflammation is atopic inflammatory mediator responsible for mast cell activation. IL-5 plays a key role in eosinophil growth, recruitment, and activation. IL-4 and IL-13 responsible for T2 helper cell differentiation, IgE synthesis, recruitment of basophils, eosinophils, and mast cells, and the mucus hypersecretion. IL-4 and IL-13 receptors share a common subunit designating alpha. Dupi works on that alpha receptor and blocks the signaling reaction of IL-4 and IL-13. Just to put you in the picture, there are several monoclonal antibodies indicated for other conditions are in phase 3 development for CRS. Omalizumab is an anti-IgE monoclonal antibody that can lower serum and tissue IgE levels through selective IgE binding. FDA approved the treatment of moderate to severe persistent atopic asthma and idiopathic urticaria. Omalizumab is being investigated in multi-centers around the world for treatment of CRS with nasal polyps. Resilizumab and Polizumab, the names actually, binding circulating IL-5 by reducing eosinophils mediated inflammation, while Bernalizumab binds to IL-5 receptors. So we have these biologics which work on the IL-5, and that will probably help a lot if they are combined with Dupi.
Dr. Jamal, I need 2-3 minutes, inshallah, معك.
Okay. Right. Dupilumab, if we go forward to Dupilumab, is a fully human monoclonal antibody that targets, as we said, IL-4 alpha and suppresses the effects of both IL-4 and IL-13 because both of them, they share this target receptor. And the Dupilumab at the moment is also used in certain adults with moderate to severe atopic dermatitis. Okay, in light of the success of biologic therapy in treating severe asthma and parallels in the inflammatory pathways involved in asthma and CRS, particularly with nasal polyps phenotype, it is expected that the biologic will have an increasing role in treating the refractory CRS with nasal polyps in the coming years. Biologic therapies have important limitations. The necessity for regular injections, twice monthly, every 2 weeks, potential for serious adverse effects like anaphylaxis and malignancies, and of course the high cost. Monthly cost here in Saudi Arabia is, I think, like 5,500, and in Europe it's 10,000 euro per year. So in the future, we need to determine the safety, efficacy, and appropriate patient selection for these patients. And optimal patient selection for biologics by endotyping biomarkers will be important for moving this therapeutic class forward in chronic rhinosinusitis management. Thank you.